Today's session is really the first in a four-part series on internal audit and compliance that we hold in the fall. I should know this, but we've held this for the last several years. Today, we've got a really nice panel of compliance and finance leaders in various healthcare organizations, health systems across the U.S. And throughout the rest of the fall, we've got various other sessions that will be coming up: cybersecurity and IT audit, data analytics, and with a focus on the revenue cycle compliance, and then finally an overview of compliance, a year in review, and planning for what's ahead. So that's going to dive into those things like OIG and other regulatory requirements and real specifics around that. To the extent you want to register for any of those, there's a link down below, and I'll pop this up at the end too. You can go to ibailey.com and you'll be able to find your way there too, but the website is down below. By way of real quick background, maybe I'll give you a little background on myself. We will introduce the panelists in just a few minutes. I'm a partner with the Minneapolis office of iBailey. iBailey is a top 20 firm with a focus in healthcare and healthcare consulting services, including internal audit and compliance. I myself head up the healthcare segment and also our internal audit services as well. Thus, my involvement today in the panel. Today, we plan to dive into a few different areas around regulatory compliance and risk, talk a little bit about compliance programming, along with challenges in today's healthcare environment, and maybe touch a little bit on board involvement, board governance. As I mentioned, our panelist has compliance experts as well as finance experts, so we'll get a little bit of a view of what's on the minds of all these people. Kind of a really quick current industry state. Certainly, we've gone through a period of 2 or 3 years of the pandemic, which really changed a lot of business practices. What came with it was new regulations, new programs such as the CARES Act and certain regulatory requirements around that, but also it changed the way a lot of organizations had to do business, and it had to pivot very quickly. Not only in the provision of healthcare and providing healthcare and using telehealth and more electronic means, and which also resulted in regulatory matters. It also changed the way a lot of organizations are doing business, whether it be from a healthcare delivery standpoint, but how all organizations are doing their day-to-day operations, including finance, compliance, internal audit, et cetera, et cetera. It really created a situation where people moved to a much more remote basis. Some of that's starting to change a bit, but I think there's still a fair amount of organizations that are heavily remote. And with that comes different processes, controls, changing policies and protocols. And then I think all healthcare organizations are continuing to look at their operations and changing maybe the way they're doing business, refocusing on service lines. Finally, as we emerge from the pandemic, what we are looking at right now is certainly extremely high costs in certain areas. So I think a lot of healthcare organizations are really challenged from an operational standpoint. Their operating margins are certainly under fire, if you will. We've seen some reports come out from other organizations that have completed surveys about 22 and into 23 really being a challenging year for healthcare organizations. Obviously, the revenue side of things, there's some limitations because of the difficulty in raising rates, particularly Medicare, Medicaid, but the organizations are faced with higher supply chain costs, certainly costs from a resource constraint, whether it be the nursing situation or really across the board in a lot of different areas. And then each of these people in their own functions are certainly continuing to be challenged with resource constraints, complete and perform the things that they'd like to do on a day-to-day basis. So we'll delve into a little bit of that and get some of these individuals' views of these particular matters as we work through the next 40 or 45 minutes of this webinar panel. As I mentioned, we've got 4 individuals coming from different organizations, a bit different size organizations as well, to give you some input and thoughts on the compliance area and risk in general. So with that, I am going to let each of these individuals introduce themselves, and we've got a little bit of background on them on on the slide, but we'll start off with Johanna, I guess, if you could maybe go a little background about yourself, experience, and the organization you're with.
Hi, I'm Johanna Brown. I'm the compliance director for Kootenai Health. Kootenai Health is a public hospital district, community-owned hospital in Coeur d'Alene, Idaho. And for those of you that may not know where Coeur d'Alene, Idaho is, it's in the very skinny part of the northern part of Idaho. So we're about a half hour east of Spokane, Washington, so right on the border of Washington, Idaho. Kootenai Health has 331 beds. We're a level 3 trauma center, level 3 NICU. We do have a couple of critical access hospitals that we own and operate that are south of us. I personally have been in healthcare compliance for over 18 years. I started out my role in compliance with HIPAA and patient privacy, and I worked for UW Medicine in Seattle for about 10 years before coming here to Idaho. And let's see, what else? I really enjoy compliance, and you know, I think that there's just never a dull moment in this field. You know, just when I think that I have all the experience and all the knowledge in the world, something new surprises me. So here we are, and I'm happy to answer any questions and kind of tell you a little bit more about, you know, some of the challenges that we're facing.
Great, Joanna, thanks, I appreciate it. And I've had the pleasure of having some involvement in Kootenai Health over the years, and you've grown substantially. The campus looks wonderful, and you've added some other hospitals, maybe a little bit smaller hospitals around the state too, which is, I'm sure, added to your workload, if nothing else, right?
Yes, it has.
Good, thank you. Nancy, do you want to go next?
Sure. My name is Nancy Klunder. I'm Vice President of Corporate Responsibility. So with that, I oversee the compliance area as well as internal audit. I also oversee the Institutional Review Board and also HIPAA security. So it just kind of umbrellas all into one. I do work for Monument Health, as you can see there. Monument Health is an integrated healthcare system. So we have 2 acute care hospitals as well as 3 critical access hospitals. We've got some specialty areas, which includes orthopedics, behavioral health. We have a hospice house, different things like that, just to name a few. I've been with the organization for going on 28 years in the compliance world for about 17 now. So just really enjoy the compliance world and just watching to make sure we're doing the right thing and ensuring that everything's in place. So.
Wonderful, Nancy, thanks. Another organization that I've worked with, and certainly a real financially sound organization, and also I don't know if you mentioned, I might have missed it, but you're in Rapid City, South Dakota, so western part of South Dakota, so you get kind of a unique marketplace, if you will, from that standpoint. So
we do,
and creates its own issues, I guess, in and of itself, right? So
yeah, we're pretty much the western part of South Dakota. So we reach, you know, from into Wyoming, and then down into almost to the borders of North Dakota, about halfway through the state of South Dakota in itself. So we're you know, we're considered small, but yet I think we're rather large from the compliance perspective.
You've got a lot of different pieces and parts there, and certainly another organization has grown quite a bit over the years. So Tim, why don't you go ahead? Tim kind of brings that finance background to the panel and some of that overall risk piece of it, but I'll let Tim give you a little background of himself.
Thanks, Scott. I am a CPA by trade. I've spent about the last 6 years in healthcare specifically. I am currently with the Ventura County Healthcare Agency. I'm a kind of a new acquisition there, so bear with me here. We have a variety of services here. We're a county-owned, taxpayer accountable agency. We have 2 inpatient facilities, about 20 outpatient facilities, including FQHC clinics, and that's the division that I oversee. We also have a public health division, and we perform behavioral health services as well, both inpatient and outpatient.
Great. And Tim is again part of a public agency. So in California, I suspect there's probably a few unique things there. Tim will talk to us about from an overall risk standpoint as they address that part of the business on a year-to-year basis. So thanks, Tim. I appreciate you joining us pretty early out for both Joanna and Tim coming from the Pacific time zone. So thank you. Rhonda, last but not least.
Sure. Hi, I'm Rhonda Raisler. I'm the Chief Compliance Officer for Avera Health. Avera Health is a Catholic-sponsored health system located in southeastern South Dakota. It's sponsored by the Benedictine and the Presentation Sisters. We also are an integrated health system. We have acute care hospitals, critical access hospitals, home care, DME, long-term care, a large medical group, an insurance division, hospice. We dabble in about everything healthcare related. We have about little over 19,000 employees and physicians, and we cover a 5-state region. I'm actually located on the other side of the state from Nancy. So she has the western part, and I'm over in the eastern part of South Dakota. I'm a nurse by background. I did a lot of obviously bedside nursing and then a lot of nursing leadership roles. My journey into compliance started in case management that led me to compliance. I was the compliance officer at our largest hospital, which is in Sioux Falls, South Dakota. And that currently has about 590 beds. So it's our big ship. And then for the last 3 years have been the chief compliance officer for the entire health system.
Great. Well, thank you, Rhonda. That's a big beast to kind of manage and keep on top of. So I'm sure we'll hear a little bit more about that. So thank you for the introduction. Really, maybe I'll kick off the first question. Certainly, as I mentioned earlier, the industry over the last 2, 3, 4 years have really faced a lot of changes. Certainly brought about changes in the way people are doing business, regulatory changes, and then of course some of the pressures that are occurring right now around cost, expenses, and operating margins. Each of you, certainly have unique responsibilities because despite some of these cost challenges, you have to make sure the organization stays compliant and manages risk, particularly regulatory risk. Could you maybe talk a little bit about or comment on areas today that you're really focused on, or the things that you really see as challenges as you look out over the next 6 months or a year? And maybe we'll go in reverse order. I'll start with Rhonda since she was the last up on the last question, so that's okay.
Sure. I really think right now the biggest thing that my compliance team is working on is really thinking about how quickly we set up everything in COVID, and now how do we start unwinding some of that. So that's one of my I say risk or a challenge right now that we have, and it's really around, I think, the space of telemedicine. We all went to that telemedicine platform pretty quickly. Billing rules kind of changed over that time span. So really looking at where we're at now, what we did then, and hopefully we did all of that correctly and set that up the best we could at the time. Home care became a very big service line for us during COVID, like many health systems did. So now really digging into what did we bill for some of the remote patient monitoring. Rules changed for provider-based clinics, and you could make a person's home the clinic. And did we do that? Did we did it appropriately? And then always, cybersecurity is a biggie for us, and that is probably one of my larger challenges of just trying to feel like that we keep our system safe with our IT colleagues. So I think that's my biggest buckets right now.
Rhonda, I appreciate that. It's interesting, the couple things you mentioned. Certainly you talked about home health and how that's grown, and I've done some of these presentations, just overall risk, and some of these kind of, I don't want to call them one-off, but they're maybe not part of your core business or core hospital business, but those are things that I've seen come up and bite organizations. So, I think have an eye on that. It's maybe not the primary focus, but it can come up and hit you every now and then. The other thing too, there was a recent study done by the Institute of Internal Audit, and interestingly enough, they had the highest risk areas were cyber and IT audit. but they weren't the area that most compliance and internal audit functions were spending their time on. Interesting enough, it was down the list. And I think probably because getting resources to handle those were a challenge. So it's interesting you mentioned those. So I might kick it over to Johanna, because I know in one of our discussions, you talked a little bit about telemedicine and those sort of things too. So I might be skipping around a little bit here, but thoughts on that?
Yeah, no, that's okay. You know, I completely agree. In fact, I think Rhonda, you know, stole my answer, because I was going to say, you know, that exactly is that, you know, we had to just stand up everything so quickly. And at the time, you know, at the beginning of the pandemic, I just feel like those waivers were changing on a daily basis. And it was so hard, you know, keeping up with them, and then also disseminating that information to our leadership and making sure that everybody knew what to do, and how, you know, how to like change their workflows to accommodate, you know, certain waivers. And so, I mean, I think that the biggest waiver that we utilized was, you know, telehealth. And maybe a couple others, probably provider-based billing. We do, you know, all of our clinics, or most of our clinics are provider-based. And so, yeah, so now we're faced with how to unwind some of the practices and new workflows that we put into place during the pandemic. And I think one thing in particular with the telehealth is, you know, it has to do with licensing. So the provider has to be licensed in the state where the patient is. And not every, you know, a lot of states had waivers on that piece of it. But because we are on the border, I mean, we're essentially on the border of Washington and Montana. So, you know, the panhandle of Idaho is just, you know, very small, like less than 100 miles. And so I think that Montana has different rules around telehealth and licensing than Washington does. So having to navigate that. We also, Coeur d'Alene is a resort community as well. So we have a lot of retirees here. And so, you know, a huge Medicare population. And so, you know, navigating people, you know, with the telehealth rules in this area is it's a little tough. So I think that we are, you know, we have a telehealth steering committee that meets on a monthly basis, and we are, you know, tracking when the public health emergency will be, you know, over. And of course, we know with the telehealth waivers, there is going to be some grace period. So it's not like just abruptly ending on a certain date. Once the public health emergency is over, we, you know, we have kind of this grace period afterwards. But yeah, we're evaluating, you know, what we're going to do when that happens.
Johanna, talk about the telehealth committee and how that came together and how you put that together. I think sometimes, you know, everyone's resource challenge and how to, you know, how to stay on top of this stuff has got to be a huge challenge. And it sounds like this is one way you're kind of trying to address that.
Yeah, absolutely. You know, so our telehealth steering committee is led by one of our physicians, Dr. Silvis, who I mean, we've actually made him the medical director of telemedicine. I mean, he also is a hospitalist here, and, you know, wears a couple different hats, but he chairs the meeting along with, we have a leader, a director, also around, I don't know exactly what is, I don't think it's director of telemedicine, but it has, it's in his title. And so he's the co-chair of this telemedicine committee, and it's multidisciplinary. So, you know, compliance and legal are on it. A couple other physicians, our clinic leadership, and our chief physician executive. And so, yeah, so we meet to, I mean, telehealth is really becoming one of our major strategic initiatives. And so while we're trying to start new telehealth projects, we also have to be mindful of the rules changing, and so we're working on that with the committee.
I assume each of those meetings, people have different takeaways or to-dos, if you will. Legal has the fun job of doing some legal research and some of the operational things and other things go other directions then.
Yeah. So, I mean, so I work pretty closely with legal on a lot of the questions that come up with telehealth, so.
Okay, great. Maybe I'll kick it over to Nancy. We talked about cyber telehealth a bit. Any reaction to those, or maybe other things too that are on your plate? I know just given the nature of your organization, you got a lot of different operations and activities going on, so.
Thank you. Yeah, we do. I mean, of course, everything that has been said so far is definitely worrisome, I think, throughout the nation or anybody that's in the compliance world. You know, another thing is that we're kind of really making sure that we take a look at our COVID vaccine requirements, were they reported correctly, things like that kind of coincide with that. You know, as far as, you know, telehealth is one of those that, of course, has always been on the radar, wanting to be able to do, just because, like I talked before, the pure vast of the area that we cover on the western part of South Dakota, we do have some areas that are pretty rural, which this would really help enable to get that covered and be able to do that for the organization. So there, you know, there's a lot of that is concerning, but then also making sure that we are covering everything else that's going on at the same time. So we're coming out of this, hopefully coming out of the pandemic, of the waivers, things like that. But at the same time, we have a lot of the different challenges that are faced with the No Surprise Act, pricing transparency, information blocking, all of that that's kind of happening at the same time. So just making sure that we're covering it all. Every one of them they're not a small topic. They're not a small thing to do. It just takes an army to do the work.
Yeah. Maybe give the group a little background of your army, although that might be overstating it, right? Your team that helps handle this and how you execute on some of these things.
Yeah, so, you know, we work really closely as an organization, just not with compliance in itself, but just, you know, HIM, working very closely with them, revenue cycle as a whole, you know, because a lot of it's dealing with them. Pricing transparency in itself takes a lot of work in that area, you know, the No Surprise. You know, again, we work very closely with legal as well to make sure that we're covering everything, that we've got all of our I's dotted and our T's crossed with that. So it just takes a lot of time with a group of individuals just really focusing in on those areas and making sure that we're getting things covered just from the beginning stages to the end and putting it into place.
Yeah, and you've got a team between compliance and internal audit that what, a half dozen or 6 or 8 people, something like that?
There are 15 in my department. I do have internal audit as well as the compliance specialist. So the compliance world is dealing with the coding, billing, documentation type of audits, and internal audit is more the business risks. Now there are times where they kind of cross over, in which works well because we collaborate with each other when that does happen. They are kept separate as far as work plan items, you know, and things like that. But we do, you know, we work really well together in that area.
I think that's a fairly common thing in healthcare. I know that you get outside of the healthcare industry and sometimes that compliance and internal audit are a bit more separated, but I think unless you're a very large organization, and Avera might be a similar, a lot of times the need to kind of share knowledge and resources and those sort of things fit a lot better in healthcare environments. So good. Thanks, Nancy. Appreciate that. Good input. Tim, again, I'm going to go to you, but you come with it at it from a finance perspective. So maybe talk a little bit about, and maybe I'll kick into even the next one, kind of when you look at compliance or just risk in general, what concerns you or what are top of mind, and maybe how has that changed from 3 years ago to today, and I'm not as familiar with Ventura County, your compliance area or internal audit. I assume you do have functions like that, but what are the things you may be talking to them about, taking a look at or making sure you get on the list? So kind of broad question. So you can go a lot of different directions with it.
Absolutely. I'd really echo what my colleagues here have stated. A lot of these areas have been integrated issues that we've been approaching as a team between our independent auditor controller, as well as our accounting staff, our revenue cycle staff, and especially with our clinicians and also our IT professionals. Really, revenue cycle. We've been spending a lot of time focusing on revenue cycle and changes there. Things moved very rapidly during the COVID-19 pandemic. There's been a lot of conversations on changes in models, as well as a move to more of a risk-based care model. So we've been doing quite a bit of due diligence with respect to what financial impact will be to some of the discussed changes at a state and a national level for our kind of entities. As a meta concern, one of the real things that we've been managing and working to manage is staff attrition, as well as staff development to focus on some of these areas. I know our volume need, especially around our audit functions and our continuity functions, has greatly increased. So growing these departments and building them to the point where they can manage these functions closer has been challenging. And really, I hammer and nail example here, but cost accounting. We've really been focused quite a bit on long-term projections, what the next 3 years are going to look like, and getting really laminar cost accounting data compared to operational drivers to help guide us through our what our actual performance was through the COVID-19 pandemic, try to spin out elements that'll be continued changes in our modeling. So that's been that's been a little bit of a challenge, but we're moving forward. We're optimistic.
Yeah. That's an interesting comment, and I'll maybe ask you a follow up, and if anyone else has some reactions. This may not be as much compliance, but there could be a compliance take on supply chain. I start hearing a little more about supply chain and vendors and access to the right products and those sort of things. How has that changed, or what are you doing differently? And I maybe throw that open to the rest of the group if they have any other comments, either within the organization or within your function. Have you started taking a peek at that? Because obviously everyone's had to be more dynamic in what they've done in this area. So
absolutely, that's been one of our biggest challenges, especially early pandemic. Prior, in agencies and organizations like mine, we will typically work with larger suppliers, and typically the conversations we were having about 5 years ago with these suppliers, most of them were looking for exclusive agreements and willing to give us incentive prices on the backside of request for proposal functions there. Where we've ended up, and I think where a lot of my cohort has gone, has been to build relationships with as many large suppliers as possible for the continuity aspects here. So not putting our eggs into one basket as far as our sterilization supplies and other critical items we need at the clinical level. I'm lucky, probably a little luckier than most on this panel, in the sense that we are outpatient clinics. So we do have we do have fairly uniform needs that we can get from multiple suppliers. So building those relationships, building those contracts, getting to a point where we can get especially sterilization supplies and things of that nature out to the clinics has been critical. One of the things that we did, with my previous outfit, one of the things that we did early on through this process is go from a more of a just-in-time inventory model where we were doing drop ships directly to the clinics from our suppliers to a kind of a blended centralized warehouse function. And we did actually run into, which helped, but we did have some compliance considerations with changes within the supply chain, because anything we were bringing in-house, chemical based, needed to be approved. We need to have policies, we need to have training for our respective staff. So that was quite an effort between us and our nursing leadership to keep that coordinated, as well as keep the clinics running.
Yeah, obviously a bigger issue these days than it was 4 or 5 years ago. And I'm not going to point to anyone because it is a bit of a narrow question. Any other thoughts from the rest of the panelists on that particular area, or if there's anything you've seen or heard within your organization? Okay. With that, I might throw out another question. So we've got 75, 80 participants out there. Most of them come from the compliance or internal audit world. And I know just in my travels, oftentimes one of the first questions I hear is, so what's new, or what's on the plan, or what are you seeing people put on the plan? In fact, there's certainly studies out there, that surveys that are done. And so I think a lot of them would like to hear, outside of the things we talked about already, which are some of the real hot buttons right now, what else is kind of on your plan, given the fact that most likely changes periodically, but I would assume most of you do develop a plan over some period of time, whether that be 6 months, a year, or longer term. Maybe talk a little bit about that plan, what's on it, what's there longer term, what's changed, and so we can give the audience a little bit of perspective of other things, and maybe give them a couple tidbits to take back to their offices. So I'll start maybe with Nancy on that one, if that's okay.
Sure, Scott. So some of the areas that we're focusing on for our work plans is the e-prescribing, making sure that the physicians are actually registered for the controlled substances, to make sure that that's in place, and everyone is registered. So we're actually doing a full audit on that to make sure that we've got that covered. Also, provider contracts is one of the bigger ones that we try and stay on top of, to make sure that the providers are paid according to their agreements, things like that. And then also we take a look at the RVU tables and monitor those, just to make sure the new RVUs that are coming out is mirrored. So those are just kind of a few things that we do kind of monitor, that we will be looking at consistently. And just revenue cycle as a whole, and appropriate billing, to make sure that we're billing appropriate. So that's kind of on our radar for the next 6 months. Our work plan is, we have 2 a year for both compliance and internal audit. And definitely, like I mentioned before, would be on the compliance risk, and then also the business risk. So that's where they kind of monitor out there a little bit more to find out where we'd like to go next.
That's interesting comment. So you do 2 a year, one for compliance and one for internal audit, or do you do 2 for each a year? Just to clarify.
I'm sorry, it should be 2 for each a year.
Yeah. Okay. No, that's what I thought. I just wanted to clarify that. Have you built in kind of gaps, or kind of things that could drop off or added if something happens during the year? Is that kind of how you build out your plan typically?
Right. We take a look at what's out there. We take a look at what's CMS looking at, what's the OIG looking at. We get calls that come in from our providers, from our caregivers within the organization, that says, can you take a look at this for us to make sure that we are doing this appropriately? We do put together, a spreadsheet which does have a list of, other types of audits that we could be doing that may be a concern. We take a look at from a heat score. Is it a high, medium, and low, so red, green, yellow. And we do have those listed as well. So any of those that kind of take a priority over something that's on the work plan does become priority at that time, but then go back to the work plan so we can get that completed. So it's constantly fluid, constantly moving a little bit, but we try to ensure that we do get the work plan done on time.
Okay. And I know this is largely a compliance panel, but I know you kind of oversee the internal audit piece. Anything unique or interesting there other than some of the things we've talked about already from an internal audit perspective?
Just kind of what I'd mentioned before, with the provider contracts, that's more on the internal audit side, taking a look at those, just making sure that we're scouring those to make sure that they're paid appropriately. A lot of it is just, it's just a constant moving basis, right? I mean, everything is, with the RVU tables, that was one of the things that, that you got to really watch the RVU tables to make sure that is consistent throughout the organization and applied appropriately. So, the business risk on that side can be more than that. So it could be that, looking at dollar amounts that are applied and things like that to, one of them be credit balances, taking a look at your credit balances. Another one would be maybe taking a look at Medicaid referrals is another one maybe to look at. There's just some of those that don't necessarily fall into the compliance side. There may be regulations, but also internal audit could be looking at it at the same time.
Do some testing around it, yeah. Good.
Yeah.
Rhonda or Johanna, you have any other comments or reaction to the general question about kind of what else is on the plan over short and long-term period?
Sure, I can add just a little bit from Avera Health perspective. We went to a new platform of our EMR, and any of you who've been in compliance know that sometimes can be a challenge. So we have really written in a lot of follow-up on just making sure that we're billing appropriately now that we had to really re-level set all of how our claims were going and those data sources. So much like Nancy, it's just that continual revenue cycle stuff, but we're really focusing on EMR and appropriate billing. The other thing that right now we're really in the middle of is, and it's more on the HIPAA and the IT side, is information blocking, which is actually kind of an oxymoron because it really is information giving. But that really goes into effect, very soon here in the next couple of weeks. And that will continue to be just tweaked as we go forward on some of those exceptions that our providers could do and making sure that they understand that, getting that information to our patient portals, balancing it with, that provider independence to keep that patient physician relationship safe. So we've been spending a lot of time in doing that right now. And then honestly, during COVID, some of our external audit that the government or other payers put on us kind of went quiet. I think that was pretty common for most of you. Lately, it feels like those faucets have been turned back on very quickly. So just the uniqueness of some of the external reviews that are happening to us too, and making sure that we follow through on those.
Without giving specifics, any particular things you're starting to see come through at all? Is it, some of the old rack audits and things like that? Like you said, really not much activity, at least what I've seen for clients I've worked with, but.
Right. No, it was kind of some of the usual stuff, wound care, podiatry care, dialysis. I mean, it's all the usual, but it just seems like there's just a lot of them coming at us all at once.
Yeah. Okay, good. Thanks. Johanna or Tim, any other additional thoughts on that particular item?
I'd
Yeah.
echo. Oh, go ahead, Joanna.
Oh, sorry. I was going to say that I'm kind of in the same boat as Rhonda. We are 6 months into our Epic go live, and we consolidated many different disparate medical record systems into that. So, I mean, the runway leading up to the go live, and all of the build work and evaluation that we did once we went live, there was a lot. And I think right now, I mean, of course, that was all last year, kind of that preparation for Epic. And it was also during the pandemic. So that was really fun.
Right.
But I think that, kind of our biggest challenge with that, impacted compliance and kind of some routine monitoring, is making sure that we had the Epic built right around our provider-based billing workflows, because it can be very complicated. And of course, I mean, without getting too much into the weeds and details, of course, we have many different grandfathered off-campus locations, but we have a couple that are not grandfathered in, so like kind of newer clinics that came on after that grandfathered date. And so that's a different workflow in Epic. And, there's different modifiers involved with that. And so, with all best intentions of us getting the build right, once we flipped the switch, it was like, oh, wait, no, we don't have this right. And so, kind of really making sure and reviewing that we had that is good. And then, I mean, that's just one example that we had with the Epic Go Live, but then, there were a couple other things that others have mentioned, but like the No Surprises Act, and making sure that we had all of the right charges and pricing information posted on our website. And I will say that we are starting to get some external reviews on that. So just the other day, we received a letter from one of our payers that was saying that we weren't in compliance with the No Surprises Act. They had reviewed our website, and it was really interesting because we feel like we are in compliance. So it's kind of, I think, maybe like some differences in interpretation. So that's hard to navigate.
Yeah, it's not my area expertise, but I suspect those will start to come out, and I suspect there's going to be education because they'll be moving into an area that they haven't had as much time to address in the past, and how to implement it. So
yeah, definitely. And then the other thing I just was going to piggyback onto Rhonda with the information blocking, with the Epic Go Live, we now have MyChart. And so pushing everything to the, MyChart patient portal, and educating our providers and other clinical staff that, the patient may see the lab results before you can actually reach out to them and tell them yourself. And also educating our patients as well that, these lab results might be available before you hear from your physician. So there's been a big push of education with information blocking as well.
Yep. Certainly some, like you said, new regulations, No Surprise Act, pricing transparency, another area I know we've heard in the past that being compliant or getting in compliance is, maybe still out there for some organizations. So, Tim, were you going to add something?
Yeah, shoot. Having a lot of the same issues. We have seen a big uptick in specifically in audits. A lot of the funding sources we utilized during the pandemic had some audit considerations there that we've been getting educated on and working with our external CPA firm on. And the No Surprises Act has definitely been a challenge for us as well as a lot of other organizations. Specifically, staffing needs. So one of the big components of that is the good faith estimate requirement for sliding fee scale and self-pay patients, which as a county and a county organization, we are one of the primary caregivers for that population in our area. So having the staffing support to do estimates and review before those encounters has been a little challenging. So we've been building up those teams and we've been investing there. But I think that's really changed the landscape on some of our processes here, and we're taking a look at that from a higher level as well find ways that we can optimize our charge master, as well as I make this as easy to navigate as possible for both our patients and our partners.
Great, thanks. With about maybe 10 minutes left, 8-10 minutes left, I maybe will kind of come back around to something we chatted about a little bit, but I think Joanna gave kind of an example of utilizing resources within the organizations, but maybe talk a little bit about resources, both internal within your department and other factors you see out there, and how you manage all the issues. It's a never-ending list of issues, right? And while there's different size functions, how do you manage those, or what do you see right now from a resource perspective, I guess? And I'll throw that out to the group if anyone wants to take the lead on that one.
I mean, I can start. I would just say really quickly that personally, my compliance team is really small, so it's just 3 of us. And so, I'm constantly relying on my partners throughout the organization. So, of course, I work really closely with legal and risk management, and our revenue cycle director, our HIM director, and just, other staff in general. So, I really want to make sure that everybody is aware of the compliance department in general. It's amazing how many people don't know what compliance is. So just getting the education out there that, we exist, and that we have a confidential hotline, and it's really important to report things. So I rely on my partners out in the organization. And as far as resource challenges go, I think that we're constantly looking for different ways to optimize current systems or software that we have. So in terms of just from a HIPAA perspective, we are implementing a privacy monitoring tool called Protenius, and it will be kind of an add-on to Epic, and it will automatically alert us to any questionable accesses into the medical record. In current state, for us to do these types of audits is a very manual process. We can pull like access logs, but then we're scanning them, and so this tool will be really slick and create a lot of efficiencies for us. So I think that helps us from a resource perspective.
Yeah, interesting. Just trying to use the resource you have and the skill sets you have within the organization. So other thoughts from others on that, on the resource type of issue?
Scott, I can jump in a little bit from Avera Health. Big system, not a huge compliance department by any means. So we've had to be creative, but one of the things that we've really done is we have a lot of critical access hospitals, we have a lot of locations, but I have across the system, we've developed compliance points of contact, if you will, at each of those locations. So they're not the compliance officer necessarily, but we keep them really involved as much as we can, and we keep them educated. Certainly they come to the compliance team for issues and all of those, but just that person locally who can help educate on some things, go take a peek if there's something that's going on that I might need looked at. And then we, as a compliance team, actually push out some reviews to those folks and ask them to just review at a small sample and
review. Nice.
Yeah, so we do that. Just for EMTALA, for example, is always a risk, right? So what does the transfers out of our critical access hospitals look like, and is the documentation sufficient? So, but we ask those local people then to just take a little peek at some of the patients for us versus trying to do all that work internally ourselves.
Awesome. Yeah, good. Any other thoughts from anyone else? I'll maybe just have one other item here as we wrap up here a bit.
Yeah. Go ahead, Nancy.
I was just going to mention that, we utilize, just like Joanna's mentioned, other departments to basically help out in different areas, IT, revenue cycle, so on and so forth. We also are trying to look forward into more data analytics. So taking a look at those low hanging fruit, things like that we can automate more rather than just spend resources in looking at that. So
anything specific on data analytics? I think that's probably another area of kind of perks the ears of some of the people as in my travels. So
Sure. When we try to do a lot of work with spreadsheets, things like that. Of course, those things can work by running reports to get those types of things. But we do have a software that we currently use that we can actually just kind of take a look at, where we're at with different things. We're just basically getting started in a lot of that area just because it's a big beast, to kind of grasp. But definitely to take a look at any of those. Ventilation, how long are the patients on ventilations is a good one. Your evaluation and management, your E&M codes to see, where are your physicians at in your bell curve. When you're auditing them, CMS is a little behind on, the way that their bell curve is, but we can be a little bit more ahead of that. So take a look at, is there any risk there? So there's different areas that we're just kind of dipping our toes into and seeing what we can do to make it more automated to help us out.
Awesome. And you lead into one of our future webinars too, by the way. So we'll be looking at data analytics primarily in revenue cycle, but yeah, some ways to use some of those tools out there. So Tim, was there anything you had? Otherwise,
yeah, couple quick points. We're doing a lot of the same. We have been leveraging technology more than we have in the past, and that's been really helpful. We're pulling in solutions like Power BI and other reporting. We're really looking for a good site level reporting solution right now. We're also leveraging more outsourced professionals than I believe we have in the past. So pulling in experts to help us through some of these quick runs, especially around areas like the No Surprises Act and other large grant programs, large initiatives, and that's been a big help.
Awesome, great. We do have one question out there, and it came through at 10:30, so I don't recall who was actually talking about, but Emily asked, can you speak more to your risk-based care model? And I'm actually not sure who to direct this to, but if anyone has a thought on that, that'd be great. Is that Johanna? Is that you?
No, I was going to say, I think it was Tim. Tim was.
There you go. Yeah, Emily helped. Thank you, Emily.
We might be able to do another hour on that one. So, California's interesting. We have a capitated model. So for the outpatient side, we operate similar almost to an insurance setup where we get a per member per month payment as well as payments on top of that at point of care that's reconciled at the end of the year for most activities within the FQHC. It's called the PPS system, or the Prospective payment system. This is actually being considered right now at the state level for what they refer to as the alternate payment methodology, which would be a complete change in our model. So right now, PPS is really focused on the definition of a physician encounter and any physician extenders. The alternate payment methodology we're really interested to learn more about as this develops. But that'll be a more holistic view of the patient care environment. So they'll provide us the ability to focus more on quality and elements of care, specifically things like diabetes education, prenatal education, other considerations that are indicative of overall health within the community and health of our patients. So landscape's been changing. We're curious. We think these will be positive changes that'll better allow us to adapt to changes within the marketplace, especially around recruiting and our ability to serve our patients timely and at a very high level.
Great. We've got just a couple minutes left. And what I'd like to do is maybe open this up to any other questions that anyone have. If you want to put it in chat, I think if there's any information on risk-based care model, you could certainly send Emily another question and I can pass that along to Tim to answer. So I'll give everyone a minute here on that. Do not see any coming in at this point. So with that, maybe again, we get 2 minutes, so it's got to be 30 seconds each. If everyone could go around and just say, what are the one or two things, we've already talked about that, but if there's anything else each of you have as thoughts over the next longer period, maybe over a 1 to 3 or 3 to 5 year period of things that really are on your plate as you try and think through and strategize what your organization looks like. And we will probably start. I'll start with Rhonda again as we started. You're at the top of my screen here, so I'll just give a quick couple thoughts on that.
Sure. I really think the next 3 to 5 years we'll continue just to see the end of that pandemic and what that looks like as we come out on the other side and we get new rules around telemedicine and what's going to stay and what isn't going to stay for that. Also, I think it's just the movement, I think, of more patients to care outside of the hospitals and even into the home settings, and what that looks like from a billing and a revenue cycle perspective is where I would be focusing my attention.
Great, thank you. Tim?
Contracts. So changes in our financial models, changes in our grant funding, different approaches to delivery care, specifically around almost a similar conversation was in public accounting and what's been going on with public accounting as far as value billing. So interested to see how the next few years roll out.
Okay, great, thanks, Tim. Nancy?
I'll probably continue our monitoring program to make sure, like with all the new regulations coming forth, everything stays in place. So we don't have any issues there. Again, like Rhonda said, just coming out of that pandemic, make sure everything's just kind of unfolding appropriately. And then again, just continuing with our data analytics and try a little bit of predictive modeling if possible. But just mirroring exactly what everybody's kind of concerned about.
Good. And Johanna, you get the last word.
Okay. Oh yeah, and we're at 9 a.m. right now. So something that we didn't mention during this at all, we have a pretty robust 340B program. And so I think that there'll be some focus on those rule changes because there are a lot of opponents to the 340B program and people that want to change that. So it will be interesting to see how the regulatory climate changes on 340B.
Yeah, and HRSA activity, right? Just
Yep, exactly. Yeah,
yep.
So that's it.
Good. Well, thank you all. I appreciate all the panelists today. We're right at the top of the hour, so we're going to let everyone go. Again, reminder of the future webinar series. And Amy, any last thoughts for the group or anything you need to let them know as we wrap up?
No, just thank you all so much for attending. We really do appreciate it. Thank you to our panelists for joining, and thank you, Scott, for presenting. We will send out a recording of this later, and we hope that you will join us on session 2 coming up in October. So have a great day, guys. Thank you all so much.
Thanks, everyone.